Hello, everyone. Thank you for joining me today. My name is Kimi Landry, and I'm a researcher at the Center for Improving Value in Healthcare, or CIVHC. Today, I'm going to be sharing work from our team, the Research and Evaluation and Innovation team. This project is titled the Colorado Autistic Perinatal Experience, a claims-based study of pregnancy and delivery. And this project is really part of our ongoing work to uncover health disparities using the Colorado All Payers Claims Database. So, CIVHC's mission is to equip partners and communities across Colorado and nationally with data and insights needed to improve healthcare quality and equity. Our vision is simple but powerful, that everyone has the opportunity to be healthy with access to equitable, affordable, high-quality care. This study reflects that vision. It's about shining light on populations our health data systems too often overlook. So the Colorado All Payers Claims Database includes medical, pharmacy, vision, and dental claims data covering over 70% of Colorado's insured population from 2013 to 2025. It contains over 1.3 billion claims from 33 commercial insurers, Medicaid, and Medicare, and is updated monthly. The CIVHC does not include specific items, including some ERISA-covered self-insured plans, TRICARE, Indian Health Service, and then the uninsured. So why this study? Why did we do this study? Autism and other pervasive developmental differences affect communication, sensory processing, and how people experience the world. Yet most health systems weren't designed with neurodiverse needs in mind. So that mismatch can lead to, and has led to, miscommunication, unmet needs, and poor outcomes, especially during major life events like pregnancy. So despite all we've learned about maternal and perinatal equity, autistic parents are still almost invisible in those data conversations. And that invisibility is what really motivated this work today. So for this analysis, we use both the current Autism Spectrum Disorder diagnostic codes as defined in the DSM-5 and the older Pervasive Developmental Disorder codes used before 2013. We included both categories to ensure complete capture across our 10-year data set because diagnostic language has evolved, but the individuals behind the data haven't changed. So this decision helped us bridge sort of the pre and post DSM transitions and minimize missed cases due to coding variation. So before diving into results, I think it's really important to acknowledge language. In this study, we use autistic individuals rather than individuals living with autism. And this really aligns with preferences from most of the neurodiversity community. It's a small linguistic shift, but it does matter, and it recognizes autism as a part of identity, not a condition to distance from. So our goal today was to describe pregnancy and delivery trends among autistic individuals in Colorado using the CIVHC. So we analyzed 10 years of data, 2013 through 2023, using retrospective cohort design with the Johns Hopkins ACG system. We stratified by age and insurance type to better understand differences between Medicaid, commercial, and Medicare populations. And the total population we identified with pervasive developmental disorder diagnosis was just over 10,500 individuals. And about 3,000 of these individuals met the definition for Autism Spectrum Disorder, making up 29% of the broader PDD cohort. So one of our first key findings is when we look over time or saw trends over time, the number of pregnancies among autistic individuals increased by about 122% between 2013 and 2023. Now, I want to point out that the population was small, 531 to 1,182. But the steady growth is something that does matter, and it means more autistic people are navigating pregnancy and delivery, often within systems that may not yet be prepared for their unique needs. And another one of the most critical findings that we noticed was that over half of pregnancies didn't have a matching delivery, as you can see from this slide. And that mismatch doesn't necessarily mean adverse outcomes. Some of it may reflect coding differences, incomplete data capture, or deliveries occurring outside of traditional claim systems. But it does signal possible breaks in the continuum of care, pregnancies that begin in the healthcare system but aren't always followed through to documented delivery. So in practical terms, that could mean missed follow-up, untracked outcomes, or gaps between maternity care, between maternity, behavioral health, and hospital claims. But it's one of the clearest examples in our analysis of how neurodivergent parents can fall off the map, so to speak, in our data infrastructure. Demographically, most pregnancies occurred among younger individuals, and the majority were covered by Medicaid. This group also had higher vulnerability scores based on their ACG risk profiles, suggesting greater medical and behavioral health complexity. That combination, youth, public coverage, high vulnerability, is a critical intersection for understanding care continuity and postpartum support. So, what does all this mean? This project really made one thing clear. Our health data infrastructure wasn't built to see neurodivergent adults, especially during pregnancy. Diagnosis coding is often inconsistent, and once individuals age out of pediatric systems, autism rarely appears in claims. Even identifying this population took careful validation and cross-checking, a reminder of how easily people can disappear from data. And that invisibility is both a challenge and an opportunity. By linking claims, electronic health records, and social data, we can illuminate experiences that traditional systems miss and design care models that better meet neurodiverse needs. Data can show us where the gaps are, but only if we ask the right questions. So what's the takeaway? We can't close perinatal equity gaps without acknowledging neurodiversity as part of the equity conversation. Inclusion in data is the first step toward inclusion in care, and visibility begins with how we collect and classify information. At CIVHC, we're committed to improving that visibility by refining data capture, linking sources, and partnering with researchers and communities to build a fuller picture of health in Colorado. Some references. And thank you again so much for your time and attention today. I'd be happy to connect after if you'd like to discuss. Thank you.